You hear a pre-assessment nurse talking to a patient, Mr. Mark Jennings, who's being admitted for an urgent appendectomy. For questions 1 to 12, complete the notes with a word or short phrase that you hear. Now, you have 30 seconds to look at the notes.
Good afternoon, Mr. Jennings. My name's Sarah, and I'm one of the nurses on the surgical ward. I'm just here to finalise your pre-operative notes before you go down for your appendicectomy. Is that okay?
Oh, yes, of course.
Great. I know you've probably answered these questions a few times already, but we have to be thorough. Let's just confirm, when did this current problem start?
You mean the stomachache? Let me think. It wasn't yesterday. No, it was the day before. So that would make it about 48 hours ago now. Yes, that's when I first really noticed something was wrong.
48 hours, okay. And where did you first feel the discomfort? Was it spread across your abdomen or in one area?
That's the strange part. Initially, it wasn't where the pain is now. It was focused right around my belly button, my navel area. It was quite a dull, nagging ache at that point.
Has it stayed there since then?
No, it hasn't. It was around the middle all day yesterday, but when I woke up this morning, it had definitely moved. Now it's really sharp and concentrated on the lower right side of my abdomen. The left side feels perfectly fine.
All right. And you said it feels sharp now. Would you call it a stabbing, burning, or cramping kind of pain?
The dull ache used to come and go, but this new one, it's constant. It's been there all morning and feels like a really strong stabbing sensation. It doesn't let up at all.
That sounds very uncomfortable. Have you had any sickness, like nausea or vomiting?
Yes, quite a bit of queasiness. I haven't actually vomited, thank goodness, but the feeling is awful. A really strong wave of nausea that started yesterday evening. I've completely lost my appetite. Food just turns my stomach.
That's quite typical with appendicitis. And what about your temperature? I believe the admitting nurse already checked that when you arrived?
Yes, she did. I felt hot and cold all night. She said it was 38.5 degrees Celsius, which sounded a bit high to me. I still feel feverish even now.
Right, so you've got a low-grade fever. Any other small symptoms you've noticed? Tiredness, chills, anything else?
Nothing too dramatic, just a sense of overall malaise. I've been feeling run down and flat, like I've no energy at all.
That's helpful. Now, I just need to check your medical history for the anaesthetist. Have you had any previous operations or procedures?
Not really. I've never broken a bone or had anything serious. The only surgery I've ever had was a tonsillectomy when I was a child, around 7 or 8 years old, I think.
Okay, noted. And any allergies, particularly to medications?
Yes, I'm allergic to penicillin. I was prescribed it for a chest infection as a teenager and developed a horrible rash all over, so I've avoided it ever since.
All right, that's clearly marked on your chart. We'll make sure the anaesthetist is aware. Are you on any regular medications at the moment?
Yes, I take Ramipril for my blood pressure, just a small daily dose in the morning, nothing else apart from the occasional paracetamol.
Ramipril, okay. And finally, any relevant family medical history, things like heart disease or diabetes?
My father's got high cholesterol, but it's well controlled. The main thing is on my mum's side. She and her sister both have type 2 diabetes, so I try to be mindful of that.
Understood. And one last, very important question. When was the last time you had anything to eat or drink?
Let's see, I had a slice of toast and a glass of water at about 8 o'clock this morning. Nothing at all since then, not even tea or water.
Perfect, 0800. That's exactly what we need before surgery. I'll mark you as nil by mouth and let the team know you're ready for theatre. The porters should be here soon to take you down.
Extract 2. Questions 13 through 24. You hear a community health visitor talking to a new mother, Mrs. Sophia Lee, during a home visit focused on maternal mental health. For questions 13 through 24, complete the notes with a word or short phrase that you hear. Now you have 30 seconds to look at the notes.
Good morning, Mrs. Lee. It's lovely to see you again. Thanks for letting me visit today. How are you and little Leo getting on?
Good morning. Thanks for coming. We're getting on, I suppose. It's been harder than I expected, if I'm honest.
I can imagine. He's looking bigger already. He must be growing fast. Let's see. He's over a month old now, isn't he? About 5 weeks old now?
Yes, that's right. 5 weeks on Tuesday. It's gone quickly, but every day feels so long.
I know the early weeks can feel like that. Last time we spoke, you were just getting the hang of feeding. Are you still breastfeeding exclusively, or have you started any formula yet?
No formula. We're still breastfeeding exclusively. He feeds well. I mean, he's gaining weight nicely, but it feels like he's on me constantly. Sometimes I think he's finished, and then 10 minutes later, he's hungry again.
That's very typical around this age. Babies have a growth spurt at about 6 weeks, so that frequent feeding, called cluster feeding, is normal. How's his sleep pattern been? Are you managing to get any rest between feeds?
Honestly, not really. At night, he's up like clockwork. Every 2 hours, sometimes even sooner. The longest stretch I get is about 1 hour and a half if I'm lucky. Just as I drift off, he's crying again. I feel like a zombie.
That must be exhausting. Sleep deprivation really takes a toll. And how is all this affecting your mood generally?
It's hard to tell, really. I'm so tired, I can't even think straight. I just feel constantly miserable. Not crying exactly, just heavy, numb, like there's a cloud that doesn't lift.
That's quite a common feeling among new mums, but it's still important we take it seriously. What would you say worries you the most at the moment?
My biggest worry is definitely the total exhaustion. It's not just tiredness, it's like my body has shut down. Even when I sit down, I feel drained to my bones.
That sounds overwhelming. Do you find the low mood is worse at any particular time of day?
It's there all the time, really. When I look at the baby, I love him. He's perfect, but I feel strangely detached from everything else. My friends keep texting to check in, and I just can't bring myself to reply. I've lost interest in almost everything.
Have you managed to go out at all? Maybe to see family or to one of the local community groups?
That's the thing. I keep saying I will, but I always talk myself out of it. I've been avoiding the mother and baby group nearby. My friend Jane from antenatal class goes every week, but I can't face all the small talk or pretending I'm okay.
It sounds like you've been very isolated. And how do you feel about yourself at the moment? Your sense of identity apart from being a mom?
That's a really good question. I feel like I've lost my personality. I used to be organized, confident. Now I just feel like I'm failing at everything. Like I've disappeared and only the baby matters.
You're not failing, Mrs. Lee. You're coping with an incredibly demanding phase, and you're doing your best. Are there any other stresses in your life that might be adding to this?
Well, yes. My husband's been trying to help, but his company recently moved him onto night shifts, so he's asleep most of the day when I really need support. By the time he wakes up, it's evening and he's getting ready to leave. I feel completely on my own.
That must be so hard, doing most of it solo. And just to check, have you ever experienced anything like this before? Any previous mental health difficulties?
I suppose I have. When I was in my early 20s, I went through a really rough time. I was diagnosed with clinical depression back then. I had counseling for about a year, and it helped a lot.
Thank you for sharing that. It's important to know, especially given your current symptoms. Based on what you've described, the exhaustion, the withdrawal, and your history, I think we should take some action now. I'll arrange an urgent psychologist referral. We have a specialist perinatal team who are excellent with new mothers.
Oh, okay. That sounds good.
And for some immediate, practical relief, would you be open to a volunteer support visit? There's a local charity that sends someone once a week for a couple of hours. They can hold the baby so you can rest, have a long shower, or even just drink a cup of tea in peace.
A support visitor? Just for me? That would be amazing. Honestly, that sounds like exactly what I need.
Then I'll make the arrangements today. You're doing incredibly well, even if it doesn't feel like it. You've taken a really brave first step by talking about how you feel.
Part B. Question 25. You hear two nurses discussing a newly admitted patient, Mr. Harris, who is recovering from a severe bout of gastroenteritis. Now read the question.
Okay, next, just a note on Mr. Harris in bed 2. He's the 68-year-old, post-op day 1 for that small bowel obstruction. His IV fluids, the Hartmann solution, are running smoothly at 80 mils per hour, and the cannula site looks clean and intact. The good news is he hasn't been sick since 4 a.m., which is a massive improvement from yesterday.
That's great. He was feeling awful yesterday. Is he still on the antiemetics?
He had his last dose of ondansetron at 6 a.m. Dr. Chen saw him on the early ward round and noted that he's improving well. Her plan was for him to start on a soft diet today, maybe soup or jelly to begin with.
Right. So, shall we get that going for lunch?
Not yet. I've held it for now. Even though his nausea settled, his oral intake over the last 12 hours has been 0. He's not asked for water either. I offered sips, but he said he still feels too full and bloated.
Sounds like his gut isn't ready, even if he's not nauseous anymore.
Exactly. And there's another concern. His urine output's borderline, only 250 mils in the past 6 hours. So I'm reluctant to reintroduce solids too quickly. We don't want to trigger another ileus or have him vomit again. For now, the main priority is hydration and monitoring renal output.
What's our target urine output again? Above 30 mils per hour?
Yes, ideally between 40 and 50 mils an hour for a few hours before we make any dietary changes. Let's keep him on IV fluids as charted and continue strict input-output documentation. Hold off on the soft diet until at least 2 p.m. If his urine output improves and he starts passing flatus or even asks for a drink, we can reassess.
Got it. So no solids yet. Keep him NBM, maintain fluids, monitor urine output closely, and review at 2 p.m. with Dr. Chen's next round.
Question 26. You hear a medical technician explaining the proper procedure for calibrating a new portable ECG machine. Now read the question.
When calibrating this new portable unit, please ignore the outdated instructions laminated near the wall. That only applies to the fixed unit. For this device, the key step is ensuring a reliable baseline. You must always run a full 12-lead trace before zeroing the device. If you zero it first, the readings will be skewed by the residual charge from the last patient. Once the trace is complete, you zero it, and then you can input the patient data. Don't forget to charge the battery overnight. That's standard.
Question 27. You hear a GP is dictating notes after consulting with a patient about managing chronic insomnia. Now, read the question.
Patient is Mrs. Davies, 55. She presents with severe chronic insomnia. We've previously tried cognitive restructuring with limited success. She requested a prescription for Zopiclone. However, I've decided to avoid hypnotics entirely due to the high risk of dependence in this age group. I believe the core issue is non-adherence to the basic sleep hygiene principles we discussed. Specifically, her reported consumption of 3 to 4 cups of coffee after midday is the biggest contributing factor. We've agreed to phase out the afternoon caffeine before exploring any further interventions.
Question 28. You hear a pharmacy assistant advising a nurse about the disposal of outdated controlled drugs. Now read the question.
We've got this box of expired fentanyl patches for disposal. Just a reminder of the process. All controlled drugs must be denatured first, typically with water or kitty litter. You know the procedure. However, for transdermal patches like these, the absolute mandatory step is that they must be individually signed off against the dispensing record before denaturing to account for every patch. Once that's done, you can proceed with the usual destruction method and then dispose of them in the yellow waste bin.
Question 29. You hear a surgeon and an anesthetist discussing a patient prior to a complex procedure. Now read the question.
We're ready for Mr. Cho. Abdominal surgery. The main concern, as you know, is the history of severe bradycardia under general anesthetic 2 years ago. We've already confirmed the cardiac assessment is clear, and we've got the full monitoring setup. I just want to be sure that the anesthetic management plan explicitly details the immediate use of atropine at the first sign of that cardiac deceleration, rather than waiting for it to reach a critical level. That's the deviation from our usual protocol I need assurance on.
Agreed. Atropine early, as per the custom plan.
Question 30. You hear a public health official discussing the importance of proper hand hygiene in community clinics. Now, read the question.
Our audit of community clinic staff revealed a troubling compliance gap. Staff are generally compliant with washing hands after patient contact, but the real failure is before contact. We observed frequent instances where staff went straight from touching high-contact surfaces, like keyboards and door handles, directly to patient interaction. This highlights a failure to understand the My 5 Moments principles fully. Remember, the rule is about protecting the patient from the environment, and the single greatest opportunity for cross-contamination comes from that environmental contact.
Part C, Excerpt 1. You will hear an excerpt from a public health webinar featuring an interview with Dr. Naomi Chen, a specialist in health communication, discussing the core drivers of vaccine hesitancy and how healthcare providers can effectively respond. You now have 90 seconds to look at the questions.
Dr. Chen, thank you so much for joining us on the program today. Vaccine hesitancy remains one of the most significant and complex public health challenges we face globally. To start, I think it's crucial for our audience to understand what we're actually talking about. How do you, as an expert, formally define it?
That's a great question, and thank you for having me. It's incredibly important to clarify that hesitancy is not the same as outright, staunch refusal. They're different points on a spectrum. We formally define hesitancy as the delay in decision-making or uncertainty regarding vaccination. It's often driven by a mix of conflicting information, a lack of trust, or specific unresolved concerns about a vaccine. It's a state of ambivalence, not a fixed anti-stance. And that ambivalence, that in-between state, is where real, productive conversation and intervention can begin.
You mentioned that in-between state. Where do health authorities, clinics, and governments most often fail in their communication strategy when trying to reach this ambivalent group?
Historically, the biggest and most damaging mistake has been how genuine questions are handled. When someone raises a specific safety concern, perhaps something they've read online, and the healthcare provider reacts defensively or worse, dismisses the question as ignorance or misinformation, the trust is instantly broken. That response confirms the patient's fear that their voice doesn't matter. It shuts down dialogue completely and reinforces their hesitation.
So let's make that practical. Suppose a patient walks into a clinic and says, "Doctor, I'm scared of this specific side effect I saw on the news." What does a truly effective, trust-building response look like?
The first step is validation. You must acknowledge their concern because for them, that fear is real. You might say, "Thank you for mentioning that. I understand why it would be worrying." Only after that should you pivot to explaining risk, and not by throwing around abstract numbers like 1 in a million. Instead, calmly compare the small, theoretical risk of that side effect with the much greater, well-documented risks of contracting the actual disease, hospitalization, long-term complications, or even passing it to vulnerable loved ones. That framing connects emotionally and intellectually.
That distinction feels crucial. Many professionals seem to think the answer is simply more data, more facts and figures. Why is that fact dump approach so ineffective?
Because it's based on what we call the information deficit model. It assumes that the only problem is a lack of knowledge, that if we just pour enough data into people, they'll automatically change their minds. But human beings aren't empty vessels. Our health decisions are guided by trust,
personal values, lived experience, and community influence, far more than raw data. If the foundation of trust isn't there, even the most accurate statistics won't land.
And how does this apply when the hesitant person is a parent? That introduces a strong emotional dimension. What's key in building trust with them?
Exactly. It's a very distinct dynamic. With parents, you start by acknowledging their protective instinct. They're motivated by love and the desire to keep their child safe. Saying something like, "I completely understand that you want what's best for your child," establishes common ground immediately. Once they feel seen and respected as the decision maker, they're far more open to hearing your clinical perspective. Without that foundation, even the best explanation can sound like an attack.
That's such a useful perspective. To summarize for clinicians listening, what's the single biggest shift in communication style that's needed?
The essential shift is moving from a model of lecturing with data and authority to one of genuine dialogue. Instead of telling, we need to ask. It's about inviting people into the conversation with questions like, "What have you heard that concerns you most?" And then truly listening without interruption. When patients feel heard, collaboration becomes possible. We must move from a monologue to a respectful, two-way conversation. That's where trust and ultimately vaccine acceptance begins.
Part C, Extract 2. You will hear an excerpt from a medical symposium featuring an interview with Dr. Clara Bennett, a consultant cardiologist, discussing the evolving approach to managing atrial fibrillation, emphasizing lifestyle and preventative measures. You now have 90 seconds to look at the questions.
Dr. Bennett, thank you for being here. In your recent publications, you advocate for what sounds like a major paradigm shift in atrial fibrillation management. What exactly is that shift you're proposing?
Certainly, and thank you for having me. It's an important distinction. Traditionally, our medical approach has focused almost entirely on treating the established disease. When we see a patient in AFib, the instinct is to reach for rate control, antiarrhythmics, or anticoagulants. The shift I'm proposing reframes AF as a progressive lifestyle disease, much like type 2 diabetes. We're moving away from crisis response and towards prevention, focusing on long-term, upstream modification of risk factors and optimizing the heart's overall environment before the disease becomes chronic or resistant to treatment.
You mentioned risk factors. Most people are aware of high blood pressure. Beyond hypertension, what is one of the most significant yet commonly overlooked lifestyle factors fueling the AF epidemic?
That's a great question. We now have robust, large-scale evidence showing that several modifiable factors directly contribute to AF. While hypertension remains crucial, the most underestimated and potent lifestyle risk factor is chronic, untreated sleep apnea.
The repeated nocturnal oxygen drops, what we call hypoxia, combined with sympathetic surges, put enormous strain on the atria, both mechanically and electrically. That strain promotes the onset of AFs and makes it far more likely to persist or recur despite treatment.
That's a fascinating link. What about weight loss? It's always mentioned for general health, but how much difference does it make specifically for an AF patient?
The impact is enormous, and the data are very encouraging. We used to view weight loss as a general health bonus, but we now know it has direct disease-modifying effects in AF. Even a modest reduction in body weight, about 10% sustained, can dramatically alter the course of the condition. It reduces both the frequency and severity of AF episodes, a phenomenon known as atrial remodeling. Essentially, the heart's electrical and structural environment becomes healthier, making rhythm control strategies like medication or ablation significantly more effective.
When this preventative focus is implemented, what is the greatest benefit? Is it primarily symptom relief, or does it go deeper?
Symptom relief, fewer palpitations, less dizziness, and reduced fatigue is a welcome benefit, but the real goal is far greater. The primary advantage of this early, comprehensive management is reducing the risk of catastrophic complications. The two most serious long-term consequences of poorly managed AF are stroke and heart failure. By addressing the underlying drivers of AF early, we dramatically cut the risk of those outcomes and, in many cases, extend both life expectancy and quality of life.
And a common question from patients, alcohol. What is the clear, evidence-based message clinicians should be giving AF patients about alcohol use?
This is one area where our understanding has evolved considerably. The data are now clear. For many AF patients, there may be no truly safe level of alcohol intake. While binge drinking, what's sometimes called holiday heart syndrome, is an obvious trigger, even low, regular consumption can destabilize rhythm in susceptible patients. The message should be about minimization, not moderation. Clinicians need to emphasize that the threshold for triggering an arrhythmia can be very low in AF, and even small amounts can matter.
And finally, to summarize this new approach, what single tool or strategy do you believe is most effective in this new era of preventative AF care?
The most powerful tool isn't a new drug or device. It's comprehensive, sustained, multifactorial risk management. That means addressing everything together, treating the sleep apnea, controlling the blood pressure, reducing obesity, advising on alcohol, and tackling metabolic and inflammatory factors simultaneously. Atrial fibrillation doesn't exist in isolation. It reflects the health of the entire cardiovascular system. By managing the whole picture, we create the conditions for lasting stability and dramatically better patient outcomes.